Good evening once again, Jan, Peta, Gay, and Rhiannon. I know that there's only three of you, but we'll go ahead and continue. And even Francis is coming in now because there are people that will be viewing this video. And so let's go ahead and get started. Our case study for today is going to be on asthma. And as we know, asthma is a big problem, and most likely a lot of questions will come out in the Nclex pertaining to this condition. So what is asthma? When we talk about asthma, this is a condition that is acute and it's fully reversible inflammation, oftentimes that is going to follow exposure to an environmental trigger. So there's a trigger that precipitates this attack. The underlying pathophysiology in asthma is reversible, and there is going to be a characteristic diffuse airway inflammation that leads to airway narrowing. And that's the problem that is associated with this condition. Now, how does it start? Well, the pathologic process in asthma begins with the inhalation of an irritant. An example of an irritant would be a pollen or a cold air, or which then, due to hypersensitivity of the bronchial structures, leads to airway inflammation and an increase in mucus production. So the pathological process begins again with an irritant, and there is hypersensitivity, which leads to inflammation of the airway and an increase in mucus production. So if we take a look at the phases of how asthma starts, the early phase is initiated by what is known as IgE antibodies. Now, as you probably might not have recalled, you have a blank screen now, because I'm going to just talk a little bit about antibodies or immunoglobulins. When we talk about immunoglobulins, also known as Ig or antibodies, there's usually different kinds of immunoglobulins or antibodies. And one of them is IgG. You might have heard of IgM, IgA, IgD, and IgE. Well, this immunoglobulin E is a type of antibody that are sensitized and are released by plasma cells. So these antibodies are released by plasma cells. And these particular IgE antibodies are going to attach to the plasma cells, and what happens is that they activate mediators. And what do I mean by mediators? Mediators are those chemicals that are released in response to an allergic response. So in particular, these mediators that are released are histamine. That's one of them. That's the most common. Prostaglandin is another one. Prostaglandin. And the third one is leukotrienes. So what are the actions of these chemicals? Well, these chemicals contract the smooth muscles. And therefore, when they contract the smooth muscles, there's going to be tightening of the airway. And this is the first or early phase of activation of what happens in asthma. Then there's another stage that happens actually, and that's perpetuation. And this is the next stage right here. These chemicals perpetuate the inflammatory response. In other words, they exaggerate and they continue this inflammatory response. And the result, when you continue with this inflammatory response, is that there's going to be an increased blood flow. There's going to be vasoconstriction and fluid leaks from the vasculature to attract white blood cells to that area. And it results in more bronchoconstriction. So when we talk about bronchoconstriction, we're talking about the response of the bronchi to allergens. And this is a result of activation of mediators from the mast cells that contract the airway. And of course, as the asthma becomes more persistent, this is now the third stage, the progression stage, the inflammation progresses and other factors may also increase the airflow limitation. So why is it that there's going to be some changes that occurs as a result of this progression? Well, the inflammatory process is going to cause several things. And one of them is going to be swelling of the bronchial membranes, as well as thick mucus secretions, as well as smooth muscle contraction. So these are the results of the chronic exposure of these cells. Now, there are several factors that are recognized as far as the development of asthma. And one of them is the genetic predisposition, specifically a personal or family history of atopy, or we call that eczema, for example, or people who have allergies such as hay fever and also asthma. So these are genetic predispositions and therefore could influence the precipitation or the development of asthma. The other things that are causes of asthma are environmental factors. People can develop asthma after exposure to things that irritate the airways. And what are these substances? Well, they include allergens, for example, toxins. Some people are irritated with fumes and second-hand or third-hand smoke. In particular, this is especially harmful to infants and young children whose immune systems haven't really finished developing. The environmental factors may also include prematurity. Infants who are born premature will most likely develop also asthma in the future. And then, of course, respiratory infections, such as respiratory syncytial virus or RSV, can damage the young children's developing lungs. And therefore, this could be factors for the development of asthma. Well, there are precipitating factors, meaning to say that there are triggers that could initiate an attack of asthma. And they include your viral respiratory tract infections, for example. Exercise. Too much exercise can also cause asthma. GERD, or gastroesophageal reflux disease, as well as chronic sinusitis, for example, are other triggers for asthma. And other things that might trigger an asthma attack would be drugs. And what are those drugs in particular? Well, aspirin, as well as beta blockers, are major examples of drugs that could precipitate an asthmatic attack. So those are the triggers for asthma. Obviously, there are going to be others, such as preservatives. Some people are going to be triggered to develop asthmatic attack with some preservatives, which include sulfites, for example. All right, so let's go to this question. Histamine is a mediator that supports the inflammatory process in asthma. Is secreted by what? Okay. Could you just type in your answer? Okay, good. The correct answer here is, it is letter C. It is going to be secreted by the mast cells, right? Let's go to a second question. Obstruction of the airway in the patient with asthma is caused by all of the following except. All right, so the correct answer here is letter C. Very good. Destruction of the alveolar wall. And let's go to the next slide. Okay, so what are the symptoms of asthma? The most common symptoms of asthma are cough with or without mucus production, as well as dyspnea and wheezing. And the wheezing is first on expiration. Then eventually it could include inspiratory wheezing as well. Okay, so initially the wheezing is going to be more on expiration, but then eventually it's possible that it could include an inspiratory wheezing in the future. Now, there are instances that cough is the only symptom. And then, of course, the other thing is that dyspnea or general tightness may occur. And asthmatic attacks, interestingly enough, frequently occurs at night or early in the morning. So that is the most common occurrence of asthmatic attacks is at night or in the early morning. So in addition to all these, expiration requires a lot of effort and it becomes prolonged. And as it progresses, cyanoses might occur because of hypoxia. So the other signs and symptoms that might accompany an attack might include diaphoresis, of course, tachycardia, and sometimes a widened pulse pressure may also occur. Okay, here's another question. Let's take a look at the question. Which of the following statements by the parent of a pediatric patient indicates further education is needed? All right, your answers. Okay, so peak expiratory flow measures expiration. And as we very well know, the expiratory phase is what's going to be very difficult in patients with asthma. And therefore, the correct answer here is letter C. I expect my child's peak expiratory flow to increase. It should decrease during an attack because of the obstruction that occurs with the hyperresponsiveness of the airway. Okay? All right. Which of the following symptom does not occur in acute asthmatic attacks? Your response. Okay, so is there chest tightness? Yes, obviously. Is there going to be overproduction of mucus, which sometimes would result in plugging of the mucus? Yes. Bradycardia is not, because tachycardia is the symptom that is associated with respiratory distress. And of course, wheezing occurs. So letter C is the correct response. All right, so what are the complications of asthma? Well, the complications of asthma include the status asthmaticus. Airway obstruction in status asthmaticus often results in hypoxemia. This is uncontrolled asthma. And the other thing that could happen is respiratory failure. If left untreated, asthma progresses to respiratory failure. like we have discussed on the first session here. And of course, the last one is pneumonia. And the reason why pneumonia might occur in patients with asthma is because there's going to be mucus that pulls in the lungs, and this becomes infected and therefore can lead to the development of pneumonia. Okay, so in looking at the presentation of the patient, what are the relevant history findings that we're going to have? Well, to determine the diagnosis of asthma, you must determine that the symptoms of airway obstruction are present. So usually this will include also a positive family history, as we had already discussed earlier, because asthma is a hereditary disease and can be possibly acquired by any member of the family who has asthma within their clan. And the other thing is environmental factors, seasonal changes like high pollen counts, mold, air pollution are primarily associated with asthma. And then, of course, you could have also comorbid conditions that may accompany asthma, like, for example, GERD. If you have GERD, the position of the esophagus is so close to the trachea that if you have an acidic environment trying to invade the trachea, then it could precipitate an asthmatic attack. And then, of course, there could also be drug-induced asthma. So the physical examination of the patients are going to elicit the following. And of course, it will depend on whether the patient is currently experiencing an acute exacerbation or not. So there may be a fine tremor in the hands due to the use of your treatment for asthma. And also, they might have mild tachycardia. Patients will usually show respiratory distress, and the way in which people respond to respiratory distress is often sitting forward to splint open their airways. And this is what's called a tripod position. Okay, so this is a position of sitting forward, and usually the patient puts their hands onto their knees in order to ease their respiratory efforts. Then, of course, on auscultation, a bilateral expiratory wheeze will be heard. In life-threatening asthma, however, the problem is that if you cannot hear any lung sounds at all, so this is a silent lung sound, this means to say that the air can no longer enter or leave the lungs. This is going to be an emergency. So if you try to auscultate the patient's lungs and you cannot hear anything, this is a life-threatening condition, and intervention has got to be done immediately. And then, of course, there's going to be signs of systemic hypoxia. Now, children in particular may have imminent arrest as a result of severe asthma. And the signs and symptoms of imminent arrest may be that the child becomes drowsy and they become unresponsive. They might develop cyanosis, and they can develop, of course, bradycardia, which is going to be the opposite expected response, and of course, respiratory muscle fatigue. So these are some of the signs and symptoms, particularly in children, that you need to be especially careful to observe, because this could lead to death or respiratory arrest. All right, so generally, how do we diagnose asthma? When asthma is initially suspected, The first step in diagnosis is conducting pulmonary function tests, also known as PFTs. And the most important measurements are the forced vital capacity, or FVC. And what is FVC? This is the total volume of gas exhaled after a forced maximum expiration. So this is a forced vital capacity, the total volume of gas exhaled after a forced maximum expiration. And if we time this at 1 second, this is now known as the FEV1, and forced expiratory volume at 1 second, both of which are decreased in asthma. So your forced vital capacity and your FEV1 are going to be decreased in asthma. So these are the first diagnostic measures that we undertake in patients with asthma. Now, in an emergency situation, the quickest way to measure airway obstruction is to measure what we call the peak expiratory flow rate, or PEFR, peak expiratory flow rate, which is essentially the fastest and the hardest a person can exhale after a full inspiration. So if you ask a patient to take in a deep breath and blow, 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 blow as quickly as possible, fastest and hardest, then this is what's called the peak expiratory flow rate. So this is like a bedside mini pulmonary function test, not quite as reliable, but very useful in an emergency setting. And normal peak expiratory flow is greater than 70% of the predicted peak flow for the client's age. So you would refer to a chart to see, based on the age of the patient, what should be the peak expiratory flow of that patient. So if it's greater than 70% of the predicted flow, then that means to say that it is going to be normal. But if it is less, then that means to say that there is severe obstruction. So the severities of acute asthmatic attacks are going to be reflected by a decrease in the PEFR, or the peak flow measures. Okay, so those are the two items that I'd like for you to remember: the pulmonary function test, as well as the peak flow measures. So these peak flow measures, you have to look at a nomogram or a chart to find out what the normal value is for that age. Okay. All right, here's the question. You discussed the early warning signs of an asthma attack and ask the patient to list some of them. Select all the correct early warning signs verbalized by the patient. Okay, easily fatigued. Yes, this is correct, particularly with physical activity. Reduce peak flow meter reading. Yes, there's going to be a reduction in the PFR. How about chest retractions? Well, chest retractions are no longer warning signs. They're already a sign of an active asthmatic attack. So this is incorrect, as well as cyanosis. And of course, breathing with activity, this could be an early warning sign. So this is correct. And nighttime coughing, that's also correct. And no relief with short-acting bronchodilators. This means to say that the patient is having an acute attack. So the correct answers are A, B, E, and F. Very good. All right, so what are the ways in which we could monitor and the diagnostic findings that you will observe in a patient with an asthmatic attack? Well, one of those things is going to be your pulse oximetry. Pulse oximetry can be very helpful in the sense that you are going to be able to assess the severity of an asthmatic attack or to monitor the patient for deterioration. The other thing are your laboratories that might be ordered for patients who are having an asthmatic attack, and they might include your urea and electrolytes in order to monitor your kidney function, particularly if the patient is going to be given a lot of medications, such as salbutamol, for example. Salbutamol, which is one of the bronchodilators that we give to the patients, one of the effects is to cause potassium to go into the intercellular space, which therefore can cause hypokalemia. All right, so remember that salbutamol can cause transient hypokalemia because the potassium goes into the cell. The other thing is, of course, ABGs, arterial blood gases, may reveal hypoxemia and respiratory acidosis. We also do an ECG because of the fact that one of the side effects, or the common side effects, I should say, of the medications that we use for asthma are going to cause tachycardia. And that is the reason why ECG monitoring is very, very important. Chest X-ray, for obvious reasons, is going to be imperative. And special tests such as spirometry, which is a method of choice to show an obstructive pattern, is going to be also be important in diagnosing the development. All right, which of the following lab values would be most concerning for a patient experiencing an acute asthma exacerbation? All right, very good. I really am very impressed with the way in which you're responding. Okay, so let's examine the pH. The pH of 7.32 is normal. The PCO2 of 50 is, of course, elevated. All right. So we have here a fully compensated respiratory acidosis. A pH of 7.40 is also normal. And the PCO2 of 34 is decreased, which means to say that there is respiratory alkalosis. And pH of 7.42, again, is normal. And the CO2 of 42 is normal. The pH of 7.37 is acid, right? No, normal. And the CO2 of 35 is normal. This is where we committed a mistake. This is acid, right? Okay, so this would be the most problematic. I'm sorry about that. It's acidic because it's less than 7.35. And because of the respiratory acidosis, this is one that we're going to be concerned about. The PO2 seemed to be stable on all of them. Okay, so you got that correct. Yes, thank you, Marisalis. Letter A, pH is acidic. All right, the healthcare provider is reviewing the ABG report for a child with severe persistent asthma. The blood gas is pH of 7.28, the PCO2 is 50, and the bicarb is 25. Which of these assessments are consistent with this ABG? Okay, your answers? All right, so let's first study the blood gas. A pH of 7.28 is acid, right? And the CO2 of 50 is acidic. And the bicarb is 25. So this is normal. So we have an uncompensated respiratory acidosis. All right. So the increased acid, whenever you have an increased acid, this has a depressant effect on the central nervous system. And this would obviously cause disorientation. So this could be ascribed to the respiratory acidosis. The increased carbon dioxide also causes vasodilation of the cerebral and peripheral vasculature, and therefore it causes headache and a flash face. So the correct answer here is letter C. So let's take a look at why letter D is incorrect. When do you see Kussmaul's respirations? We talked about that yesterday. It is going to be found in patients who have a collection of ketones and therefore gives the classic prolonged expiratory phase. And muscle twitching is not going to be accompanying respiratory acidosis. So usually it is going to accompany calcium imbalances, but not in this particular one. So why is letter A incorrect? It says rapid deep respirations and paresthesia. Rapid and deep respirations would be reflected in the blood gas by a low CO2 because you're going to blow off the carbon dioxide. And that is the reason why this is going to be incorrect. And then, of course, the slow respirations is going to be incorrect as well because in acidosis, there's going to be an increased effort in patients to blow off this carbon dioxide, but not in the pattern that we have seen in Kussmaul's respirations. Okay, so Kussmaul's respirations is only associated with diabetic ketoacidosis. So the correct answer is letter C. Now, whenever patients are asthmatic, it's classified into 4 general categories. The thing to remember is that most patients don't reach a certain level and they stay there. Asthma changes over time in response to triggers. And that is why it's important to keep monitoring and managing the asthma of the patient, even when it seems to be under control. So we say that an asthma is intermittent asthma when the daytime symptoms are less than 3 times a week or 2 times per week. And the night symptoms are also going to be less than 2 times a month. So there's no need for you to memorize this, but the purpose of this chart is to tell you that there are several degrees of asthma severity, and they could be grade 1, grade 2, grade 3, and grade 4 based on daytime symptoms, nighttime symptoms, and peak flow while exhaling. So as you could see in grade 1, it's 80%, And in grade 4, it is now less than 60%. Remember, the normal was 70% supposedly. And so therefore, the more the peak flow is going to be lesser from the nomogram, the more severe the asthma is going to be. You assist your patient with using their inhaler. The inhaler contains the medication budesonide. Before administering the inhaler, you will want to connect what to the device, blood device to the inhaler to help decrease the patient from developing what? Yes, the correct response is spacer. The thing here is onide is a steroid. So anything or anytime you see the suffix onide in a drug, this indicates that the drug is a steroid. And so the problem with steroids is that when it's not rinsed from the mouth in particular, or the oropharyngeal area, it now is going to decrease the ability to fight off infection. And the most common infection that will invade the mouth is going to be thrush. And therefore, that's the reason why we use a spacer. And the purpose of the spacer is, of course, to prolong the timing of the exposure of the respiratory tract to the particles that have been delivered by pressing on the canister. So the correct answer is C, in as much as budesonide is an inhaled corticosteroid. Okay. Let's discuss the medical management of patients with asthma. And the pharmacological treatment starts with short-acting beta agonists. And we refer to this as SABA, which stands for short-acting beta-2 adrenergic agonists. These are the medications of choice to relieve the acute symptoms and prevent exercise-induced asthma. So examples of your SABA would be albuterol, and it could be Proventil, for example, Ventolin, Acuneb, or levobuterol or Sulpinex. These are short-acting beta agonists. All right. The other things that are going to be part of the therapeutic regimen of patients with asthma are anticholinergics. And anticholinergics, they inhibit what is known as muscarinic receptors, and therefore it reduces the vagal tone of the airway. Thus, it causes bronchodilation. An example of anticholinergics would be your ipratropium, that's also known as Atrovent. And the other one is tiotropium, but tiotropium is a long-acting anticholinergic. This is what's called Spiriva. So those are your anticholinergics. Corticosteroids. Corticosteroids are most effective in alleviating symptoms. They improve airway function, and they decrease peak flow variability. So it also is going to decrease the inflammatory response. And so an example of your corticosteroids that we use would be Solucortef, Medrol, Solumedrol, and so on, or prednisone. These are examples of corticosteroids. Budesonide or Pulmicort is also the classic example. All right, so you remember the leukotriene is one of those modifiers that were released by the mast cells. So if you give leukotriene modifiers or anti-leukotriene agents, they are potent bronchodilators, and therefore there's going to be a improvement of the symptoms. An example of that is going to be montelukast. And so if you see the Lucas, that's leukotriene agents, because the other leukotriene modifiers is Saper-Lucas. Okay. So Montelukast is singular, that's the trade name, and the Saper-Lucas, the trade name is accolade. But it's much better to always look at the generic name. Okay. And then immunomodulators are those that prevent the binding of IgE to the basophils and the mast cells. An example of that would be omalizumab. And this is usually given as an injection. All right. So in going back to the pharmacologic therapy, what I wanted to emphasize here is that whenever you are giving medications of different kinds, you always administer the bronchodilator first. And then 5 minutes later, if you have to give the steroid, you're going to give the corticosteroid. So that's important. That's a very common question in the Nclex. So bronchodilators first, then wait for 5 minutes, then followed with, if it is prescribed, followed by your steroid. Okay. All right, the chart on the right just tells you about what the usual daily medications are for intermittent asthma. So as you could see in step 1, there's low dose inhaled corticosteroids taken whenever SABA or short-acting beta agonist is taken. And for step 5, you're going to have a high-dose inhaled corticosteroids and long-acting beta agonists. So this just tells you the progression of the therapeutic interventions for these patients, which indicates the patient understands risk with albuterol sulfate and ipratropium bromide or DuoNeb nebulizer treatments. Your answers? Yes, okay. So this interacts with some common blood pressure medications. And the reason for that is the side effects of your beta agonist drugs as well as your anticholinergics would be to increase blood pressure. So letter B is the correct response. Excellent. A patient has an acute asthmatic attack, which drugs must be used to reduce the symptoms immediately. Okay, which are for the immediate relief. Great. Letter A is the correct response. You would give your beta agonist. Okay, good. All right, continuing with medical management, there are other measures, obviously, to approach the management of patients with asthma. Like, for example, measures to take include calming the patient to get them to relax, moving outside or away from likely source of allergen and cooling the person are some things that are outside of the usual that we do, but they are conservative measures which might be helpful. Sometimes removing the clothing and washing the face and mouth to remove allergens is sometimes done. And then, of course, weight reduction in patients who are obese leads to improved control. Now, immunotherapy or allergen immunotherapy is a controversial approach wherein large studies really have shown that there has no significant benefit. And the thing is that this particular approach is very expensive. That's when they give you several allergen triggers to stimulate the production of antibodies. Now, the other thing is smoking cessation, occupational change, and sometimes self-monitoring, which means to say that the patient is going to be taught to determine what might be the possible triggers and therefore to avoid them. In evaluating the management of an asthmatic child, which statements by the mother would be most concerning? So most concerning. So we're looking for something that is bad. Your answer? All right. Great. Letter B is the one that's concerning because this means to say that this patient is having severe attacks and therefore this is concerning. The patient is using her rescue inhaler 4 times before her breathing improves. She needs more treatment than the short-acting beta agonist. Okay. All right. A child with an acute asthmatic attack came to the ER. What should be the nurse's first priority? Your response? Okay, so we need to assess the airway and the respiratory status. As I said earlier, a silent chest might be an indication that there's no exchange going on, and therefore that should be a priority. So there are health education responsibilities that we have. We need to educate the patient regarding the nature of asthma, as well as the treatment of asthma, and also about the medications, particularly about the use of rescue medications, the difference between rescue medications and long-term controllers, and also to make sure that we discuss triggers to the patient. Now, believe it or not, pursed lip breathing is usually going to be taught to these patients because it helps in the expiratory phase of the patient. And then, of course, optimal health practices like exercise, the value of fluids, and relaxation techniques, and if appropriate, quitting smoking if applicable, as well as support groups. Those are important interventions to include in anybody that has asthma. Which medication below blocks the function of leukotriene for the treatment of asthma? Okay, so you remember the suffix Lucas, as I had earlier said. Whenever you see Lucas as a suffix in a drug, it is an anti-leukotriene agent or a leukotriene modifier. So that's the correct answer. All right, another responsibility that we have is to actually teach the patient about peak flow meters. And peak flow meters measure the highest airflow during a forced expiration. So we need to teach the patient that they need to have daily peak flow monitoring, and it must be done daily. It helps measure the severity of the asthma and, of course, indicates the current degree of asthma control. So if peak flow monitoring, it helps to measure asthma severity. And when you add it to symptom monitoring, it indicates the current degree of asthma control. All right. You also need to teach the patient how to perform or to measure it. And so this is the way in which you're going to do it. So there is this indicator right over here. You need to put the indicator to the lowest level, right? And now you're going to take a deep breath and inhale and blow hard and fast with a single blow into the peak flow monitor. Do not cough or spit during this time. It will cause a false reading. Place the meter above the tongue. That's how you would do it. Close the lips around the mouthpiece and blow out as hard as possible. And then, of course, you check the number. The patient is supposed to repeat the procedure 2 times and then record it. Okay, so this is the picture of how it should be done. This is an example of a peak flow meter. As you could see, this is the valve that I was talking about that you need to put all the way down. And then, of course, as the patient breathes, it now is going to be able to measure the volume that he or she exhales. All right, which statement by the patient demonstrates they understand how to use the peak flow meter? Okay, very good. The answer is letter C. This option is obviously the correct response. Option A is wrong because this device monitors how controlled a patient asthma is and if it's getting worse. It doesn't make the lung stronger. Option B is wrong because the patient exhales as hard as possible. See, it says inhale, and that would be incorrect. And option D, if the flow rate of 90% of personal best, this is a good reading. It's not a bad reading. Okay. Great. The correct response is letter D. We want the patient to exhale hard and fast. Over here, it says exhale slow and steady. And over here, the emphasis was on inhalation. It should be on expiration. Okay. So there are important measures that should be taught to patients in order to prevent triggers. So this include cover pillows and mattresses should be allergen-proof covers. We also advise the patient to wash all the linen at least once weekly in hot water. This is to remove any potential allergens that might have contaminated it. And keeping the dress in a closed closet. And the reason for that is if you have the clothes in an open space, it's most likely to be contaminated by triggers. And therefore, this is going to be a good practice. Then vacuum and dust the room weekly. And while doing it, the patient must wear a mask. Remain outside of the room during cleaning if you have a severe dust allergy. If possible, use air conditioners and keep the windows closed. Change the filter of the air conditioning frequently and avoid both active and passive smoking. So the reason I included this is because it's one of the most important teaching interventions that you're going to have to include in your care plan of care. And so these are environmental measures to control asthma. So there's a lot of teaching that we have to do. And the other teaching that we need to emphasize is what if a trigger is exercise induced? Well, the patient does not need to quit exercising. To help decrease the chances of an attack, what can they do? Well, they can warm up before exercising for at least 10 to 15 minutes. And they could administer a short-acting beta agonist before exercising in order to prevent the asthmatic attack. And because the asthmatic attack during exercise is caused by breathing in cold air, we need to emphasize to the patient to breathe through the nose instead of the mouth during cold windy days to warm the air before it enters the lungs. So the reason for that is cold air can make the smooth muscles around the airway constrict, and therefore that's why we like to emphasize that they need to breathe through their nose. And then, of course, avoid exercising or when sick with a respiratory illness. All right, which of the following actions can help prevent asthma attack during exercise? Okay, so select all that apply. All right, B and D are correct. Very good. Option A is wrong because the patient should warm up, right, for at least 10 minutes before exercising. And option C is wrong because the administration of short-acting beta agonists should be before the exercise, not after. Okay. Now, this is an illustration of the zones that oftentimes is referred to when patients have asthma. And green zone means to say that they're safe, which means to say there's no coughing, there's no wheezing, there's no chest tightness or difficulty of breathing, and their peak flow is going to be normal, 80% to 100%. The yellow zone, however, is when the peak flow is 50 to anywhere from 50 to 100%, but there's coughing, wheezing, chest tightness, or difficulty of breathing. And they have symptoms with daily activities. So the intervention here is to call the doctor if they're in the yellow zone for more than 24 hours. The red zone is going to be the thing that indicates that they are in a bad state. And therefore, what they need to do is to make sure that they are going to call the doctor right away. So this is characterized by a peak flow of less than 50%. So what I'm saying here is that anytime the patient's peak flow is less than 50%, this is an emergency. The patient should seek medical intervention right away. Okay? All right, which of these assessment findings require immediate action by the healthcare provider in a patient presenting with asthma? Oh, yes, very good. Letter D. If you cannot hear the breath sounds, that is an emergency, all right? And this means to say that the patient has a severely compromised bronchoconstriction. Okay. Yes, the correct answer here is letter D. It's one of the side effects. Cromolyn temporarily causes sneezing, sometimes burning in the nose, and itchy, watery eyes, and a bad taste in the mouth. The bad taste in the mouth is the one that is very classic for this particular drug. So usually we need to just reassure the patient that these symptoms are temporary side effects of this medication. All right. So I'd like to just ask your permission to go ahead without a break because we are very close to the end. So rather than having a break, let's just go ahead and continue if you are okay with that. Okay, great. So what are the complications associated with severe asthma? One of them is status asthmaticus. And this is a life-threatening complication when airway obstruction is unresponsive to the usual therapies that we have talked about. So actually, when you have status asthmaticus, it could lead to accumulation of air in the pleural cavity, and that is what's called pneumothorax. And it could also lead to cardiac and respiratory arrest. So what are the signs and symptoms that we need to be mindful, therefore, in monitoring for these complications? Well, they include extremely labored breathing or severe bronchospasm, which is unresponsive to therapy within 60 minutes. Dyspnea, and they could not even talk because of the shortness of breath. They're gasping or they're unable to speak. Use of accessory muscles and then respiratory rate above 35 with tachycardia, and your pulmonary PEF is going to be less than 100 liters per minute. And of course, hypercapnia, which is going to be a CO2 level of more than 50. So If the patient is going to be experiencing status asthmaticus, what you need to do is that you need to administer oxygen and, of course, prepare for immediate emergency intubation. And usually, these patients will have to be put on mechanical ventilation. Okay, so those are the interventions that are going to occur. And as you could see over here, oxygen, inhaled bronchodilator, systemic steroids, and high doses of steroids as soon as possible, because this decreases the inflammatory process. A patient is prescribed salmeterol and fluticasone, which is the correct order in taking them. Okay, so over here, erol and azone. Azone is a steroid, fluticasone. So just in case you forgot, azone is the suffix of steroids, and therefore the steroid has to come last, right? So the bronchodilator inhaler, which is salmeterol, is going to have to be administered first to open up the airways. Then the patient is supposed to wait for 5 minutes and then administer the corticosteroid right over here. So by giving the bronchodilator, you're opening the airway so that when you give the steroid, it can easily enter the airways and therefore decrease the inflammation. Yes, letter C is the correct response, all right? So during an asthmatic attack, what does the patient need? Well, he needs something that will quickly open the airways. And the medications that are best for this would be a short-acting bronchodilator, such as albuterol. The other types of bronchodilators right over here is going to be theophylline. Theophylline is usually given PO, right? Although it could also be given IV. But if it's given PO, therefore it's not going to be, what do you call that? Fast acting. And tiotropium is a long-acting bronchodilator. It's an anticholinergic bronchodilator, and therefore this is long-acting. It will take a while for it to act. And cromolyn is an allergy medication. It's non-steroidal, actually, that doesn't provide quick relief. So the correct response is albuterol. So let's now go to the case study. I know that one of you was able to access the case study. So let's take a look at it and respond to the questions. The case is the nurse cares for a 23-year-old male in the ER who is experiencing acute shortness of breath. And we now have a nurse's notes entry at 11 o'clock. The client reports shortness of breath and chest tightness that has progressively worsened for the past 2 to 3 days. He has a history of seasonal allergies, a non-smoker, and lives at home with his mother, who is a current smoker. denies fever or vomiting, describes feeling fatigue, and has a dry cough at night. At 11:15, audible and expiratory wheezing heard throughout the lung fields bilaterally. Increased respiratory rate noted. Capillary refill is less than 3 seconds. Skin warm to touch. Chest wall is symmetrical with no deformity. Client sits upright and leans forward, resting his hands on his knees in tripod position, and only speaks a few words between breaths. Tenderness and palpation of the chest wall. Trachea is midline with no deviation. Labs drawn, chest x-ray ordered. Okay, so the temperature is 97.8, pulse is 98, respiratory rate is 26, the blood pressure 114/78, and the pulse oximeter is 95%. The nurse assesses the client on admission. Which findings require immediate follow-up? Immediate follow-up. Select all that apply. All right. Shortness of breath, yes or no?
Yeah.
Yes, okay. Obviously, we need to attend to this shortness of breath. How about the chest tightness?
Yeah.
Yes, very good. How about the respiratory rate? The respiratory rate is 26.
Yes.
Yes, obviously that is a fast respiratory rate. Dry cough.
Yeah.
Yes, okay. How about audible and expiratory wheezing? So you can
Yeah.
hear it even without the stethoscope. Yes, that's concerning, isn't it? Tripod position.
Yeah.
Yes. Speaks only a few words between breaths.
Yeah.
That means to say severe dyspnea, isn't it? Blood pressure, 114. No, okay. And tenderness of the chest wall. That doesn't seem to be a very serious finding, isn't it? You probably are going to have tenderness of the chest wall when you cough a lot, but you're not going to die from it, correct? So that might be correct. Okay, so in the scoring of SATA, or select all that apply, you know that in the new generation Nclex, you are scored right minus wrong. So it's better not to over answer. Okay, if you are not sure about a particular choice, do not gamble with it, because it's right minus wrong. Do you get me?
Yeah.
Okay. So let's go on, and for each potential finding, click to specify if the finding is a risk factor or not a risk factor for asthma. Okay. Family history, is this a risk factor?
Yeah.
Yes. Okay, so we're going to do this. Allergies, is this a risk factor?
Yes.
Yes. You remember when patients have previous allergies like hay fever and eczema, these are risk factors. Beta blockers.
Yes.
Yes, because beta blockers block the effects of beta 2 receptors, and therefore would cause, what do you call that? Bronchoconstriction, right? All right, so this is going to be a risk factor. Edema. Is this a risk factor? No. Okay, good. It's not a risk factor. How about viral infections? Yes, like respiratory syncytial virus, for example. Smoking. Yes. Being overweight. Yes, this is a risk factor. And how about diabetes? All right. Diabetes is not a risk factor for the development of asthma. So that would be how we would approach that. Okay, great. And so let's move forward. And it says, the diagnostic reports now are here. Chest X-ray results hyperinflation of the lungs. The lab report shows these. So the nurse should recognize that the client is most likely experiencing A, pneumonia, pulmonary edema, acute asthma, or pneumothorax. Right over here, this question, what is the correct answer? Asthma. Okay, very good. What is the evidence? As most evidenced by sleep apnea, the vital signs, the shortness of breath, the expiratory wheezing, orthopnea, or the fatigue. Which one is the classic one? Yes, Rhiannon, very good. It would be the wheezing that's going to be the expiratory wheezing. That's going to be the characteristic of an asthmatic attack. Okay, so the presenting assessment most suggests acute onset of asthma as evidenced by wheezing. Wheezing is often the first sign of asthma or an impending asthmatic attack. Okay, so we have these. I think we already had that information, but the question now is, which of the following interventions should the nurse anticipate including in the plan of care? Select all that apply. Okay. So would we administer 2 liters of oxygen because the patient's oximeter reading is 93% when it's needed? Yes or no?
Yes.
Yes, very good. So I would do that. How about administer albuterol nebulizer every 4 hours as needed?
Yes.
Yes, we would need that because that's a short-acting beta agonist. How about place the client in a supine position?
No.
The patient will not be able to breathe. Administer low-dose aspirin.
No.
No, aspirin will not help anything. In fact, it might be a trigger. How about administer labetalol? Alol, what is this?
No. Beta block.
That's a beta blocker. No, very good. Administer ibuprofen. Do we need ibuprofen?
No.
No. Okay. Raise the head of the bed.
Absolutely.
Yes, absolutely. Administer Solumedrol, milligrams IV stat. Okay.
I
So
think so. Rhiannon
yes,
said yes.
yes, this is Solumedrol. This is going to be a steroid. We need that to decrease the inflammation. So we need to give it IV, and that would be good. How about offer fluids by mouth?
Mm.
If the patient cannot speak because he's very short of breath, if you give them fluids, he is going to drown, he's going to aspirate. So yes, anybody who has a respiratory problem needs more fluids, except for pulmonary edema, obviously, because they lose water through respirations. But if they are short of breath, it is contraindicated to give anything by mouth because of the risk of aspiration. So that would be a no. Very good. And so let's go to the orders now. The orders that were given is monitor the pulse oximeter continuously, administer 2 liters of oxygen as needed for nasal cannula to maintain 93%, albuterol, ipratropium 250 micrograms, place peripheral IV, and instruct the client on peak flow meter use for at least 2 times daily. Okay, so those are the orders. Monitor, albuterol, ipratropium, peripheral IV, and instruct the client. All right. So this is the question. The nurse reviews the physician's orders and considers the needed teaching. What are you going to do on these orders? Should you do it immediately, within the hour, or before the end of the shift? Okay. Instruction. Should we do that right away when the patient is very short of breath, within the hour, or before the end of the shift? Rhiannon said end of the shift. Okay, very good. Excellent. Any teaching should be done when the patient is no longer acute. When a patient cannot breathe, they are not going to be listening to you. Okay. How about administer 2 liters of oxygen by nasal cannula? Should we do it immediately, within the hour, or at the end, before the end of the shift? Immediately. Okay. Administer Solumedrol. Rose said ASAP, as soon as possible. Yes, this is going to help in the breathing of the patient. How about I'll administer albuterol in a ipratropium nebulizer treatment. This also helps in opening up the airway, correct? So it would be immediate. Instruct on pursed lip breathing. Yeah, this would be within the hour because it would help in controlling the respiratory distress that he's having. So instead of waiting before the end of the shift, you could do it once you had given the bronchodilator. So I think that within the hour would be good. How about instruct client on home meds? Before the end of the shift, yes. And apply continuous pulse oximeter immediately. Okay. So this sounds easy, right? But when you're in the Nclex and taking the exam, I'm sure that a lot of times you're going to be confused. But anyway, I think you did a very good job in selecting and prioritizing what your actions are going to be. Okay. And the last question is that the patient now at 13:30, the nebulizer treatments and Solumedrol were given, denies shortness of breath or difficulty breathing, lung breath sounds are improving, client can speak in full sentences, and tolerates activity of daily living well. No reports of fatigue. So overall, the picture shows that the patient has improved, right? And the temperature, as over here, the pulse 88, the respiratory rate 18, the blood pressure 116/78, and the pulse oximeter 98% without any oxygen. So the nurse reassesses the client at 13:30. After implementing the physician's orders, the nurse determines that the client's status is A, B, or C. Is the client improving, deteriorating, or is the patient unchanged? All right, so this is A. And the nurse should prepare the client for discharge, resume the breathing treatment, or continue to monitor the client's breathing. All right, and you already answered A. Yes, that's correct. Prepare the client for discharge. There's no reason for the patient to be admitted. Okay, so that ends our presentation on asthma, the case study on asthma. So I hope that you had gained some confidence in answering these questions. Now, I wanted to tell you that on Monday, we're supposed to start pharmacology, but actually we have one more case study because we were cheated out from the holiday on Monday. So on Monday, we will have another case study, and the case study will be on congestive heart failure. So once again, I want to thank you. I know that this is the weekend, and so you wanted to relax anyway, but nonetheless, this is a good opportunity for us to share, and I really appreciate all your participation, and I look forward for you to once again come and join me on Monday. So once again, thank you so much. You have a good weekend, and I will see you on Monday. Thank you. Sure. All right. Have a great one.